Hello and welcome to Grief Tending. This is a podcast series that aims to support anyone who's in a caregiving role to someone who is grieving. And these conversations are seeking to cultivate our collective capacities to be alongside grief in supportive ways. I'd like to start by acknowledging the traditional custodians and owners on whose unceded lands these interviews were recorded, the Turrbal and Yagara peoples. I'd like to acknowledge their ongoing connection to land, waters and culture, and to pay respects to elders past, present and emerging, and to extend that respect to any Aboriginal and Torres Strait Islander listeners. This episode sits within the health professionals stream of our series and is a conversation with Bridget, who is a licensed clinical social worker. Bridget works as part of the mental health team of palliative care practitioners in the United States, who between them have more than 100 years combined experience in clinical care. Bridget became a social worker to help people living with serious illness, and over the course of the last 10 years, she has worked across various healthcare settings, providing support and companionship to patients, families, community members, and providers. In addition to her clinical work, she's a writer and educator and edited Palliative Care, a guide for health social workers, which was published by Oxford University Press in 2019. Her practice is rooted in a commitment to social justice and understanding illness and caregiving within the context of a unique life. Above all, she seeks to promote connection and well-being. So the title of this episode is Specialist Palliative Care Social Work, Humanising Healthcare and Honouring the Whole Person. And we started our conversation there by revisiting the unique role that social workers hold in palliative care to contextualize and offer insight to the broader interdisciplinary teams in healthcare of the ways in which grief and trauma and suffering and systemic injustice can impact patients' capacities to communicate, to process information, to even engage with healthcare systems and processes. And how important that role is in terms of advocacy for individuals and families, for translating sometimes very complex medical speak to ways in which it will connect and be understood for people, as well as in being alongside in skillful ways the grief that is there. We then also stepped on from that to talk about the tension. It can be a healthy tension, but tension nonetheless, of the skill set that social workers or psychosocial practitioners more broadly, you can include spiritual care in this as well. Often those staff are able to hold people's grief experience in a very skillful way, but that this can also bring with it a default that in addition to busy caseloads, this can end up also being an expectation for other staff, colleagues and wider teams as well, and that can put kind of additional amounts of pressure onto specialist social workers. And so that led us to the recognition of a need for grief-informed care to be shared and held collectively by any healthcare professional in and outside of palliative care contexts. We talked about some skills and some very practical examples of how to go about cultivating, what John Vervaeke calls an ecology of practices, different skills and different practices that we can draw on at different times that will often be quite personalized to us, that would connect in more meaningful ways than sometimes being forced to do collective reflective practice exercises if that's not how, or group sharing, for example, if that's not how someone, if that's not what someone might find helpful or supportive. And then finally, we talked about the book which Bridget co-edited with, I believe, two other pioneering and well-respected palliative care social workers in North America. And this book really explores, 8 different domains of palliative care in line with the kind of core principles that sit within social work of social justice and holding systems holding an appreciation of the ways in which complex systems can lead to, and kind of negative and challenging impacts for certain populations, and how social workers can play a supportive role in not only helping individual patients and families to navigate the health system, but also the experiences of palliative care that involve grief and loss and death. So I found this a really rich conversation, and I think this episode's relevant for anyone working in palliative care. If you've ever been curious about what it is that and that particular skill set that social workers hold, that particular perspective, or it may be that you're a student and just starting out and wondering, what it is that would draw someone to work in a space like this. Whoever you are, wherever you are, I hope that this episode will offer you some helpful and supportive insights. Thank you. Hi, Bridget. Thanks for joining us today. I wanted to start by asking you around, your role as an educator within palliative care social work, as a practitioner and kind of researcher, as an educator who's passionate about improving the quality and standard of palliative care social work education. Share with us some of the most significant things you think that the specialty of palliative care social work has to offer, maybe more general, if someone's listening to this as a more general, either health social worker or a social worker practicing in other areas.
Yeah, I mean, two sort of overlapping but huge, worlds that I think about a lot. Being a palliative care social worker, being a social worker in a healthcare space, with a team in particular, because I think they're very different experiences when you're kind of just out there trying to figure it out yourself, trying to get people to talk to you versus, really being held and thought of as an essential component of a care team. So talking about that experience in particular is just such an honored and privileged place to be in the sort of belly of the beast of healthcare, especially if you're in an inpatient setting, which historically is the predominant place that palliative care social workers have existed. Although, that's sort of partializing things out from hospice work and palliative care work, and now this sort of building outpatient palliative care space. But to be a psychosocially minded person who gets to remind physicians and nurses about wholeness, about social context, about structural inequality, about communication styles, about psychological coping and family functioning is just a huge job. But, what an honor, because what are we doing if we're not trying to contextualize every person that we care for in their unique life? And we need teams to do that. It's not fair. It's not fair to assume a physician can do that by themselves. It's not fair to assume that I can do that by myself. I need my physician colleagues, my nursing colleagues, my chaplaincy colleagues to help me contextualize a person. So, palliative care social workers are just in an extraordinary place to help mediate this big medical world for real people and be this sort of professional lay person in that, my first year in practice, I was in a fellowship, so it was particularly demanding. But I came home and sort of had my head on the table every night after work because the level of medicine learning was just, the learning curve was so steep. Just to learn the language that you have to learn to hang, right? But then once you sort of get some proficiency there, to be a person that knows the questions to ask the doctor to help a patient or family or caregiver understand their situation better, like, what a powerful role. And it is really a role of like mediating, interpreting, helping information flow back and forth and sort of translating it, knowing how to say something that a doctor will understand and then turn it back and make sure that a patient and family understands. It's existing on like the periphery or on the borders of a lot of different realities. It's incredibly demanding in like a very fulfilling way.
Yeah. Yeah.
And then I guess I'll just say, like, to the sort of larger social work context, I really believe in the power and in the importance of palliative care social work as a field, and the continuation of proficiency. And I am more or less comfortable with the concept of expertise all the time, but professional space. I love this particular specialty, and I think that the ethos of social work practice and the ethos of palliative care are so reflective of one another, that social workers everywhere, with some training and support and encouragement, are in great places to respond to basic palliative care needs, because both fields start where people are at, want to understand who this person is in the context of their life, what's important to them, what's their value system, who helps them, what are they worried about. We want to align and help people make decisions that feel congruent with their lives. I mean, there's just so many pillars of both things that are aligned. And I think one of the biggest challenges or barriers to that is obviously just social work caseloads, right? Every social worker has more patients or more clients than they can care for. And if there's time and support to, again, build our comfort, our capacity to just be curious about transitions in people's lives and illness and death, any social worker can really be an extraordinary support to people in those transitions.
You were speaking before about the multifaceted way in which transitions can impact, a patient or a family's experience through a palliative care experience, and specifically the ways in which grief is interwoven in transitions. And as you were talking, I was wondering how much responsibility maybe is placed on social workers in palliative care to be the ones naming the presence of grief. It's so often unspoken in the task-oriented kind of medical checklist kind of framing, that actually grief's presence can impact people's capacity to even engage with the medical processes.
Yeah. I mean, I think social workers are positioned, social workers and colleagues in chaplaincy, right, are really sort of either positioned or position themselves to be the sort of, community crier, the person that's like, this conversation's not moving forward because they are deep in their grieving process. They know that they have passed this place where like life will never go back to where it was, and they can't move from there right now. We can't, I think in palliative care sometimes we think like, oh, if we, communication is one of our sort of extraordinary skill sets and tools. And sometimes you cannot communicate through emotion that just needs time or space to move its way. And a hospital is a very hard place to have emotion that moves its way. So yes, I think social workers are in a position to highlight that. I hesitate in thinking that we should, as a profession, be the primary folks to do that for our teams, because I wonder about what it does to us. And I think that maybe the vision is building that kind of the grief proficiency in all team members, so that we are all raising it for each other, so that someone can look at me and be like, Bridget, like, I see you, and I think this is activating for you. What can I do? You want to time out? You're 9 months pregnant and that person's 7 months pregnant. Do you need some space, right? Just to slow it down for me too, right? But I think psychosocial and spiritual care providers often take the role of team supporter, and that's great. As long as A, it's a role that you feel like you're really getting to choose, and B, somebody is also doing it for you. But I hesitate a little bit with the sort of like, oh, social workers are so well positioned to do this. All social workers should do it. And it's like, yes, and we're also human beings who are having our own processes and our own lives that are informing our sensitivities and how much we have to offer and to hold the process for patients and families and consulting teams, and also our teams and also ourselves, is a lot.
Yeah, I think those are really important caveats that you name, in terms of as long as it's a role that someone's chosen and not been pushed into, and as long as there's people who are doing that for you as well. So I suppose if there's other health professionals listening who aren't social workers or psychosocial practitioners, wondering, how can I support my social work by leaning into your own kind of capacity for grief literacy, and not outsourcing that completely across the table.
Yeah. It's so complicated because, like, so many people in palliative care or end-of-life care or serious illness care, service in general, like, there's really, for a lot of people, a sense of calling, right? You feel there's something really, like, about being in this space that sort of dissolves the classic personal and professional separation, right? It makes those borders kind of pixelated. And these are jobs. And not everybody wants to do a lot of emotional processing or grief sharing at their job. It's not comfortable. It doesn't feel safe. It's not how their balance of introvert and extrovert doesn't lend that to being restorative. And so it's this real tension and, dynamic to figure out on teams around how do we know this is affecting all of us. We want to be proficient. We want to tend to it. And we have to respect the individual relationship to what is work and what is professional, and when do those overlap, and when does somebody really need those to be separate. And if you're talking about a team of 5 people, and that would be a small team, like, that's a lot of dynamics to manage and to try and be aware of, right? So I don't necessarily have strategies for that so much, but just the reminder, the awareness that, like, it's a very intimate professional space. And sometimes we expect our colleagues to be more intimate than they're comfortable being or want to be or have any interest in being, and that's okay.
It's a really important really important point, particularly with what you were saying around hospitals not necessarily being a conducive space, or healthcare facilities in general not being a conducive space to necessarily working for emotions working their way through. Like you were talking about that in terms of patients. The same could be true for professionals as well, that actually it's going to land quite differently for different people how they will tend to that grief. And for some, having a workplace debrief meeting or some sort of ceremony even or something might be very, very helpful. Some people might still find that helpful but want to come and not say anything or not speak in any way.
Right. What I have heard from many of my colleagues across professions is wishing that there were not necessarily more spaces to process our grief together, but that there was more education around actual things people can do to sort of induce grief processing, right? More tools, more skills. And, that orientation towards like skills and tools and things to do is very, makes sense in medicine. Like that's congruent. And yet the calling or the yearning that I hear there is like, I know there's something I need to tend to. I don't know how to do it. And I don't really want to do it at work, but I do want to do it. And could you help me with like some ideas about how to do it, but not like pressure me into like a self-reflective poem or something? Like healthcare loves poetry, but like not everybody's bag for making good sense of hard experiences.
And could you share more about that? I suppose if that's something that you've heard people be in conversation with. So, aside from poems or writing.
Like what to do. Yeah.
Or even some of the wonderings in those conversations, I think might be helpful for people because they're things that I think are very relevant.
Here
as well.
Yeah. I think I do think a lot of people find writing, not necessarily just like journal writing, but like prompted writing. That's like, you sit down with your pen and paper and there's a 3-minute timer and the prompt is, I wish you knew ... And you write until the timer goes up, right? And you have no idea what's going to come up. And for a lot of people in medicine, this is like extraordinarily uncomfortable. Like the rules are, you're not editing this. This is not like, it doesn't have to make sense. You could say the same word over and over and over again, right? It's a creative stream of consciousness process that is very vulnerable for some people and uncomfortable. So it's not for everybody. But I do think that that's just like an incredible tool to sort of start to unearth like, oh, I didn't know that like the thing I want you to know is that story. I haven't thought about that since I was in the 2nd grade. That doesn't seem like a thing to me, but apparently it's right here. So those sorts of reflective processing that, are private. It's just you and your paper and you do with it what you want. I think, a work friend, a person who understands what you see at work all the time, who you also have a personal connection with, that you can imagine having that connection, even if you didn't share the professional context, and creating non-work spaces to be together, right? Taking those walks and just being able to talk about the patient you saw in clinic that you're thinking about in the middle of the night, and to not have to explain to them the level of stimulation that comes from the beeping in the ICU or the structural system dynamics that cause so much distress and stress for providers. But I think there's something to like, being in a non-work context and seeing each other in normal clothes and maybe being interrupted by your kid calling, like where your whole life gets to exist there. And I think there's a lot of integration that can happen there. And for me, the like one number is important because I think when the work is so intimate, there can sometimes be a pretty high expectation that you have friendships with a lot of the people that you work with. Um, and that's possible for some people and not possible for others. And it's a lot of intimacy on top of a lot of intimacy. And so, maybe there's a person where the connection just feels like, oh, yeah, I want to know her, even if we're not working together. And I imagine I could know her for a really long time. I think therapy is really helpful. And just, unadulterated spaces to talk about and share what you experience and what you've learned and what fears you have because of it all. So I think those are some things.
Yeah, they sound, very supportive and very, very intentional. Because I think, as you talked about the work friend, I imagine lots of people would consider that they have some connections at work that they might say that they're friends about, but
Right.
it's another step to bring the intentionality of, or the request or the invitation to that friend of, could I actually bring, not just in a venti, like I haven't even asked permission, I just need to vent or dump it, but kind of some intentionality of, share with me, what is it that is, some of the heavier things you've carried this month or this year around the work.
Yeah.
That made me think about, typically these activities or recommendations, in another episode, we were talking about self-care and how it can get like, kind of hashtagged almost like, please not another, yoga video or something.
Bubble bath with Grey's Anatomy on the laptop and the
exactly. So Netflix was the next step.
Yeah.
That actually, I think there's this potential for, so I'm someone who, for myself, I like to spend a lot of time by myself to reflect on the work.
Yeah.
But it was an interesting thing to come to an awareness of actually, going for a bushwalk, as they would say here, or going for a hike, it's something that again falls into that Netflix glass of wine territory, typically. But going for a walk with some intentionality of, I am taking this grief, or I am taking this incident that happened or something on this walk, and expecting to be, or looking to be, or asking to be in dialogue with the environment I'm in, or space that I'm in, to tend to that grief. So it's like without words, sometimes without any humans, you're just with the more than human space.
Yeah. I mean, it goes back to something we were talking about earlier around like, it can be enough of a start to expect grief, right? It can be enough of a start to say, like, I'm going to take this walk and I'm going to invite or be curious about or just let be the heaviness that I felt with work. I'm going to pay attention to that for a second. Or I'm going to pay attention to what it feels like to walk on this path. But if there's something, like just the intention of like, this is a space for that. I don't have to do something. There is not a process for me to go through. I'm not doing this right or wrong. I am just saying, I know this is here. I know I want to be engaged with it. I don't totally know how.
Yeah.
But here we are. And I happen to have 45 minutes to myself. And it feels possible. It doesn't feel, maybe it feels a little stressful, but the kind of like good stress because, you're engaging in something that's a little bit uncomfortable, but needs to happen or you want to have happen.
Yeah. Yeah, absolutely. And that invitation for people to lean into that in ways that feel congruent with their own
Yeah.
values,
Yeah.
personality, like all of those things. I think that's so beneficial to consider that,
Yeah.
that team of five you mentioned, there will be a need for, I think John
Yeah.
Bevere, he talks about like an ecology of practices, that there's a need for
Yes. Totally.
very different ways of being.
Yeah.
So I really value that, highlighting and recognizing that. So thank you.
One of the my son's preschool does something called listening partnerships. And a listening partnership, or for any parents that want to do it, you're paired up and you have a 20-minute or 15-minute phone call once a week at a same time every week. And each person goes for an agreed amount of time. And Jess is like, blah, 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 blah. 4-year-olds are, holy God, a 4-year-old. Like, this is, wow. So I'm on my knees humbled. Whatever you need to say, a lot more colorful than that on some times. And the point isn't to respond. The point is to give and receive your experience, and then, give your experience and then receive somebody else's. So it's not strategies. The validation comes from the engagement through the quality of the listening. And there's something about moving it out of our bodies in that way that I think is helpful. There's something about hearing yourself say it. There's something about hearing somebody else talk about something that's not on your mind, but resonates so much that it's just like validation stew, I think. And I think listening partnerships would be like a great thing for us to do also.
Absolutely. Yeah. Particularly that they're listening partnerships and not fixing partnerships.
Yes,
Takes
totally.
the pressure.
Yeah. And, venting is great and venting has its place, but it's also nice to just be able to say your piece and then like close it and not then engage with somebody else's reactions or interpretations or perspective about it.
Yeah. Yeah. Thank you for those reflections. Yeah.
Yeah.
I wanted to also ensure that I asked you about, the book that you co-edited in recent years. So in 2019, you were co-editor of a book called Palliative Care, A Guide for Health Social Workers.
Yep.
So I wonder, could you introduce us to the book, and then, talk to us a bit around what some of the response has been, and particularly which parts of it you think have been beneficial for maybe highlighting some conversations or some aspects of practice that might not necessarily often be widely enough discussed.
Yeah. So this guide was a project of my mentor, Terry Altilio, and then a colleague, Megan Limena, that was many years in the making. Started in 2014, I think. We surveyed social workers around sort of how they learned to be palliative care social workers and where they felt confident and what they didn't feel confident in, et cetera, and crafted this book around the 8 domains of palliative care. And what we wanted this was to be a affordable field guide, essentially, for healthcare social workers. But I think it's written in a way where it really, the patient stories are healthcare based, but I think that it's written in a way that can really be accessible to social workers and interprofessional colleagues, highlighting the 8 domains of palliative care from a psychosocial perspective. And a couple of things were really important to us in the framing of this book and the sort of like theoretical foundations that we rested on, which is, ecological systems theory. So like really thinking about a person in their environment. Who is this person? What is their reality context? And related, how can we understand that, from an intersectional perspective that really considers power dynamics and systems of power and oppression that position different people very differently. And so we wanted to make the social justice ethos that's so talked about in social work, but often not really concretized alive in the lens. And so we went, we collected authors from across the country, experts in their work, and tried to write a cohesive book. And I think there's a lot of richness, but we really tried to explore the theory while giving information through lots of tables that link to tools and model styles of documentation and highlight interventions and how you talk about those interventions to interprofessional colleagues so that they understand what you're saying. And the feedback has been that it's an incredible primer in palliative care. It's a good learning tool for social work students, for social work practitioners who are wanting to integrate more palliative care into their practice wherever they may sit. And I think it does what I was talking about earlier, which is just shows how obviously aligned social work practice and palliative care practice are. So it was an incredible labor of love, if you can believe it. The three of us, this was pre-pandemic, the three of us edited every chapter on the phone, reading them out loud to one another. It was an extraordinary co-editing process. And we did that because we didn't want to chunk it out and feel like there were sort of different tones or styles in sections. We wanted there to be a real through line. And I think it does a pretty good job. I'd love more people to read it and get more feedback of any flavor.
Well, that's one of the reasons for asking you, is hopefully that, people
thank you so much.
I think particularly the framing of those key domains of palliative care, but then bringing in, as you've said, into the intersectionality, but also the ecological systems approach, and highlighting the need for translation. I was talking at the start of our conversation today around the important role of translation and navigation in the healthcare system. And so then bringing into that how people navigate when they are positioned with much less power or much less agency than typically is afforded other people that might be taken for granted. There's such important things to be highlighted. And I want to thank you and the other authors for taking that labor of love time.
It was true. It was really an honor to get to take the wisdom and the words of, folks with 10, 20, 30 years of clinical experience and, cohese all of those versions together to make this tool. Mm-hmm. And I think it is so much about learning and creating a language so that we're all often, right, kind of talking around a similar thing, and we don't totally know that that's what we're doing. So how much can we, the orientation around the 8 domains of palliative care is this is how people think about palliative care. Let's orient to these structures so that we can be a part of the conversation, so that we can help to shift it in the ways that we feel like would make it bigger or better or more inclusive.
Yeah. Well, thank you so much for bringing your role in bringing that resource to the world. I'm sure it will continue to be beneficial for people. I suppose a quick final question I want to ask, oftentimes for people finding their way, especially in palliative care, but with particular regard to grief, they've often found their instruction or their mentorship or their guidance outside of the healthcare system in these things. So for you, I just wondered if you'd be open to sharing maybe it might be a book or a teacher or mentors. It's who was influential for you in crafting your own kind of development of your relationship with grief?
Frances Weller is a psychotherapist and grief facilitator who is also from Northern California, who long before I was in palliative care got connected to him through other folks in my community, and his work around grief and grief ritual has been extremely powerful in my life. I think Pema Chodron's work around uncertainty, Alan Watts' work around uncertainty, Joan Halifax's work around actually being with dying people. What does it mean to actually stay in your body and be in that experience? All sort of pillars of how I came to understand myself in this space. And now, increasingly, it's the, it's the stories of people who are living their lives through it, not in a professional capacity. I just devoured Laurel Braitman's new book, What Looks Like Bravery, around how she's faced many losses in her life, including that of her father. And, that's the stuff that grounds me now, right? Like you get familiar with the theory or the theoretical orientations or the psychological processes that we talk about and are important to be oriented to. And then at a certain point, it's like, it's real life people living through it.
Yeah.
Not with that professional lens that actually makes me feel way more connected and remembering of a skill set, in touch with a skill set or a support capacity.
Yeah. Yeah. It's a deeply human skill set at the end of the day.
Yeah, totally. Totally.
Yeah.
Thank you for asking. It's nice to reflect on that.
Thank you so much for sharing that and all that you've shared with us in this episode, Bridget. We really appreciate it.
Yeah, such an honor to be here with you. Really nourishing for me.
Thank you.
Yeah, thank you.